Is there a link between diabetes and pancreatic cancer?
And if so, what does this mean for diabetes patients and for pancreatic cancer prevention?
Dr. Richard Frank, a cancer research expert, is dedicated to study this link because it may have very important and significant implications. It may also produce very promising results for patients.
He joins us next for an important discussion, so stay tuned.
Hello, I'm Dr. Eric Mazer.
And I'm Dr. Andrea Peterson. Today on Health Talk, we're honored to have Dr. Richard Frank. He's a frequent guest on our show. He's joining us for an important and exciting discussion.
Dr. Frank is the director of the clinical cancer research for the Western Connecticut Health Network, and we'll be talking about one of the most difficult and resistant malignancies, i.e. cancer of the pancreas.
Welcome back to the show.
Thank you for having me.
Thanks so much for being
So,
here.
Rich, we said at the tease, that diabetes and cancer of the pancreas, I don't think people usually think of those in the same sentence.
Yeah.
Well, why are they related, and why may that be important?
Well, both obviously are focused in the pancreas. The cancer of the pancreas develops from cells in the pancreas that are different from the insulin-producing cells that that live in the tail of the pancreas. The pancreas has a head, a body, and a tail. But
It's almost like a snake or something
Yeah,
in the body, stretching
right.
across it.
for some reason, there's like a reverberation. When the cancer develops downstream of the tail, it affects the processing of insulin, processing of glucose, and the ability of the body to respond to insulin. It's not a direct invasion of those cells. It's thought that the developing pancreatic cancer releases things into the bloodstream, hormones in a sense, that alter glucose metabolism and create diabetes. Eventually, like 75% of pancreatic cancer patients in their course will be diabetic.
I didn't realize that's incredibly high. I think we now have scared about 50% of the population at home with diabetes. If you have diabetes, does that mean you have pancreatic cancer?
Right, absolutely not. Of course, 9–10% of the population can have diabetes. And pancreatic cancer affects 55,000 individuals a year.
So there are many, many people in America, and we're talking mostly about what we call type 2
Correct.
diabetes, which in the past had been associated with adult age as opposed to type 1 diabetes, which is really
Obesity and
failure,
like
but
sedentary behavior. We know.
we're seeing type 2 in younger patients now, but it's associated with obesity and metabolic derangements throughout the
We're really
body.
talking about something different here. My understanding is that these are people that are sort of going along normally and suddenly develop diabetes, not necessarily having risk factors, weren't expected to be diabetics. And why might that be important for patients at home? Because it's really the pancreatic cancer is what's going to kill them.
Right. So right now, there's no standard of care to analyze someone with diabetes for pancreatic cancer, and that's what we're looking at. There's basically three aspects. One is when someone is over the age of 50 and they're diagnosed all of a sudden with diabetes, the risk of pancreatic cancer, although very low, is highest in the first 2 years, 2 to 3 years. That's the peak. And then if someone has diabetes, continues to have it for the rest of their lives, over 10, 20 years, there is a slight increased risk. So chronic diabetes is one of those factors, just like obesity or smoking, alcoholism, things that raise the risk of pancreatic cancer. It's a minor effect long term, but in the immediate, those that are going to develop pancreatic cancer, a lot do in the first few years, and that's the patients we're studying. But we're also learning that people who have diabetes for long term, they're under very good control, then all of a sudden, the control gets lost, even though they've been compliant with medication and diet. There's a higher incidence of pancreatic cancer in that group of patients as well. So it's
You're
really
looking for clues that there are some patients out there, early clues, that they may be developing pancreatic cancer.
That's right. We don't know who to screen for pancreatic cancer. We screen women.
Why don't we just screen everybody?
Yeah.
That's what the people would say out there.
Yeah, you can't. Well, that's first of all, there's a screening test has to be effective to catch a cancer very early, so that if you remove it, it's a high chance of cure. So you have to prove that. And the second is you need a test that's pretty easy to do and it's relatively cheap, but we'll put the cost aside. But to do a widespread screening test like colon cancer, putting a stool on a card, hemocult test, that's pretty cheap, easy to do. Such a test doesn't exist for pancreatic cancer at all. For any of the cancers, really, the ones we know how to screen, PSA is easy because it's a blood test for prostate cancer.
Those are also much more common cancers
right.
than pancreas.
That's right.
So maybe say a couple words about the problem screening for rare cancers, or not rare but uncommon cancers.
Of course, the real effectiveness of a screening test is highly dependent on the population screened. If you screen the whole population for pancreatic cancer, the cancer is not frequent enough so that you will get a very low yield and you may get false positives. It's just not worth it. So which population should be screened for pancreatic cancer or other cancers? So that's what we're trying to find out.
So what you're saying essentially is if you can narrow down from everybody to a group of patients who may have a higher risk
Correct.
to begin with pancreatic cancer, then that makes a screening test even better.
Absolutely. That's what we're trying to define. And others are too, to see what is the real incidence of pancreatic cancer in those who develop diabetes. It's a question that's very much being appreciated and needs to be investigated.
And so you're looking at patients who've had a really rapid change in how their body is handling glucose, and trying to see if some of those patients you can detect early pancreatic cancers, and hopefully early enough that one can intervene.
Correct. And so 99% will not have pancreatic cancer. So we do not want to cause any
I
harm.
think that's important for people to hear.
We don't want to raise great fear and scare people. But we don't know. And we do hear from primary care physicians that, oh yes, I've had patients who I diagnosed diabetes and a year later they had pancreatic cancer. I wish we could have known that. I wish we had your study then. So we're asking people to really help us. The likelihood is they will not have pancreatic cancer. We're not looking.
Rich, is there any cost for them to participate in this research study again?
Right. So the cost of MRI and the interpretation of MRI are all covered. There are no costs to the patient.
So maybe tell us a little bit about the details of who's eligible for the study and what does the study entail?
So if someone is over the age of 50 and in good health, with good kidney function and can undergo an MRI, which has been, you'll talk to Dr. Ronald Lee, who's heading the radiology group, helping us to look more specifically at the pancreas and try to avoid finding non-specific things in the abdomen.
Yeah, we should talk about that a little bit later.
Talk about that later. So if someone who's pretty healthy and all of a sudden they develop diabetes, they're over 50, they would be eligible. And they would call our research nurse. She would meet with them, enroll them, take a sample of blood just for research purposes, because we ultimately do want to find a blood test for pancreatic cancer.
So we're looking at blood elements, but that's not really going to be the screen. The screen is going to be the MRI exam.
Correct.
Now, does someone need their primary care doctor or doctor to refer them into the study, or can they do that themselves?
They can self-refer. We do prefer to work with the primary care doctor. We don't want to draw any specific labs like kidney function that they may need for the MRI. We prefer that all be done with the primary care, and we want to partner with all the primary care doctors. But people can
And
just
do they have
walk
to be in the Norwalk area, or think they'd be, anywhere within the sound of our voice?
If they're willing to come in every 6 months to meet with the nurse, and once a year to have an MRI, they can come from anywhere.
I was just going to say, there's a number for them to call. Perhaps you could give that out. We'll run it on the screen, but what's the number that they should call if people are interested in participating or want to see whether they're eligible?
Yeah, 203-855-3551.
Lots of fives, 203-855-3551.
Yeah.
Okay, well, hopefully we'll repeat that before the end so people can get their pencil and paper. So again, now we talked about screening for pancreatic cancer. Right now there is no screening that we use routinely. Tell us a little about pancreatic cancer, because pancreatic cancer is one of those where a successful screen could have tremendous impact on survival. So tell us why that is true about pancreatic cancer.
Well, that is the hope, and that it's been difficult to show in a lot of cancers that screening really does save lives. It took several large studies to show lung cancer screening does save lives. So you can often catch early problems, but to prove that it saves lives is the real important aspect. There have been studies from Europe in high-risk individuals, those with strong family histories of pancreatic cancer, who are screened, and that early cancers are found and survival is increased compared to less than 10% 5-year survival for everyone else.
So off-the-street pancreatic cancer is
it's a nightmare.
Mostly fatal.
And for many patients, part of the issue is that they don't have a lot of symptoms.
Correct.
Until the cancer is quite advanced. And so you're trying to find out who are those patients we can look at, find the cancer as early as we can,
right.
and see if we can save lives that way.
That's right. If you have developed a symptom, it's really too late.
Yeah.
So
pancreatic cancer sits in an area, as you said, that doesn't cause problems. It grows, it metastasizes, and then you may want to say a couple of words about, we hear about radiation and chemo and maybe some of these new drugs for treating pancreatic cancer.
I'm not saying there haven't been advances, and people are surviving longer.
It used to be 6 months. When I was early in oncology, it used to be somewhere around 6 months. Now I think it's well over 2 years.
Yeah, I mean, if the cancer has spread to the liver or around the abdomen or outside of the pancreas, the survival is still on the order of a year, although many people are living longer with chemotherapy. And then there's a group of people called borderline pancreatic cancer, where the cancer needs some treatment first and then can be removed. And about 20% of those individuals are surviving 5 years once they go through a very rigorous program of chemotherapy, sometimes radiation to shrink it to enable a surgeon to remove it. And then there's the minority of people who present perhaps with early jaundice. They turn yellow. The tumor has grown right into the bile duct
so that's
to
almost
block.
a good thing when it does that.
Right.
It gives us a signal that it's early.
And those people like Ruth Bader Ginsburg, others who have survived, that's often the case. It just happened to grow at the perfect area, caused jaundice, hadn't spread, and got a favorable outcome.
And we're hoping that using the diabetes and this new MRI procedure will help us find more patients like that, not necessarily with the growth near the bile duct, but a growth that is small, hasn't spread, and can be surgically resected.
Absolutely.
And I think we have some information for our viewers to bring up on the screen about the study. And it's on the screen now, the pancreatic
So Tammy
cancer
Lowe
study.
is the coordinator for this study, is that right, Rich?
Yes.
And that's the number to call. I think this should be available through the internet too. But this is really an important study.
It's a screening study.
The screening study.
Yeah,
And again, so now if we find somebody in this screening study with a tumor mass, they're going to get sent off to a specialist and have that evaluated, right? They're going to get the results of this.
So the radiologist, and Dr. Lee will talk about that, have set up a system of grading the level of suspicion of abnormalities. If something has a high suspicion, they go to a procedure called endoscopic ultrasound. Gastroenterologist puts an endoscopy tube in there with an ultrasound, and they can biopsy any suspicious areas to prove or disprove it's cancer.
This is incredibly exciting
important.
about one of the cancers that I think are most feared, just because there's so little that we can do if we don't catch it early. Rich, thank you so much. Thanks for creating this study.
To have you in our community.
Thanks.
This is a
running
real
this study.
asset to all of Fairfield County. Thank you
Absolutely.
so much.
Thank you so much. Unfortunately, we've run out of time. We'd like to thank our guest, Dr. Richard Frank, for joining us on Health Talk today for this really important discussion.
If you have comments and questions for Andrea and me or about this show, please email us at healthtalk@wchn.org. We are always pleased to hear from you.
Thanks so much for watching.
And be well. Rich, thank you very much.